Minimal residual disease has now become a very important part of both myeloma research, clinical research, and it's beginning to become important part of our patient care. Number of studies are now showing significance of attaining MRD negativity. If I crystallize the finding, it suggests that deeper the response, better. So if we can get MRD negativity with 1 cell in a million, that probably gives us the best outcome. Those patients who get there have the biggest and best PFS and best overall survival. The second message from most of the studies done so far suggests that if you get MRD negativity, irrespective of the treatment utilized to get there, they do all same. So if patient has a less treatment or more treatment, if they are MRD negative, their outcome would be very similar. Now this data needs to be prospectively confirmed. So this current results forms the basis of ongoing studies to confirm it. I would not stop treatment right now in patients. So if patient got MRD negativity with induction regimen, can we prevent or avoid transplant? We don't have an answer there prospectively done today. That's an ongoing study. But the ongoing study is based on the finding that that probably is the case. The third important message is that if we get MRD negativity, then the risk doesn't matter. Patients who are high risk do similarly well as patients who are standard risk if we get MRD negativity. What it tells us is that we should push to get MRD negativity in standard risk, but even more so importantly in high risk disease. And so I think these are the three general messages that we can crystallize today. How do we utilize it in clinical practice? I think we are beginning to look at patients' MRD before transplant to see if they are attained the maximum cytoreduction. More cytoreduction, the better results of transplant, and that's the significance of it. Number two, post-transplant, we do MRD measurements to prognosticate how well this patient is going to do. And then we can also evaluate the impact of maintenance treatment. So during the maintenance treatment, 20% patients attain MRD negativity, and that's an important endpoint. So as we give maintenance, those who are not MRD negative, we would now observe them to be becoming negative. We can predict they will have a better outcome. The question that's not so clear is that if after all this treatment, if patients are MRD positive, do I do something else? Do I do second transplant? Do I do CAR T cell? Those questions are still to be worked out. So I would not suggest changing practice just based on this. But there are a number of time points where I think MRD is becoming very important to follow and to be utilized in prognosticating and to some extent deciding how well the patient is doing. Length of maintenance treatment, consolidation are not entirely MRD driven today, but I think very soon we will be deciding how long a maintenance to be given based on MRD negativity.